Professor. Sorry about that. Hey everyone, we're here with Professor Hewitt from Seton Hall University, and she's going to be talking to us today about the current healthcare system in the United States and how it compares to other countries. Professor Hewitt, how are you doing today?
I'm doing just fine.
Okay, so I want to start off simple question. Many people are talking about affordable healthcare and how the only reason why countries like Canada, Netherlands, Germany, or other European countries are able to afford healthcare is because they pay more taxes than the U.S. Do we really pay that little in taxes for our healthcare?
Well, let me start off by saying that no doubt we do spend more per person than any other country. But I think we have to put that in context of how much we actually do pay. And second of all, we have to look at that word that you used, taxes. Most countries operate on a system where they're like a company. In other words, they have a benefits package for their population. And when you say, are we paying more than others? Yes, but those other countries may be receiving other benefits that we do not give to our population. So it's a big pot versus a small pot. But there is no doubt that you are correct. Yes, we do spend more. Now, the next issue we have to address is what you said about taxes. How is our health care system funded, excuse me, here in the U.S.? Well, we certainly have two big players, that is the Medicare and the Medicaid system. But those are paid, the individuals who receive funds from those, the healthcare providers, those are paid based on payment scales. So I think when you think about total amount of taxes, you also have to look at, is it really a tax, or is the government taking out of its general operating monies covering these services that have been mandated through law? The other thing that I want to talk about in your question is that idea of affordable. Affordability is a way of looking at how much or the ability of a population to pay for a service. So my question might be, has the U.S. topped out? Are we at the point where the average person, the average American, can no longer afford health care? And we're casting around looking at other models, such as universal health care in Canada and the Netherlands, and saying, okay, they seem to have a better system than we have, although there are also pros and cons to both of those. So I think it's a supply and demand question. We have a wonderful supply of health care here in the U.S. The population demands that health care. And as you know, in any kind of economic equation, the more you do, the larger the supply, the greater the demand, the cost is going to go up.
Yeah, and I'm glad you brought that up. I was reading an article in the New York Times this past August, and it was detailed about the phenomenon of people taking trips to their have surgeries done overseas, essentially medical tourism. Now, hip replacement surgery in 2007 in the U.S. would have cost about $100,000, but we see that people will rather opt out if they have the funds and the availability to go to Belgium and get a hip replacement surgery for $13,000 and about 660. And healthcare costs at home continuously increase. So why are healthcare costs so high?
Well, I think you gave a wonderful example, and second of all, I would also go to Belgium, not to have my hip replaced, but I would also go. It's now being called destination medicine, and it really sounds intriguing. You kind of like the idea of, well, why do I have to spend this money when I can go somewhere else and get it? But what you have to realize is that you're paying for a package of health care when you do this destination medicine. It's very different than the way health care is delivered here, where you would have the additional follow-up. You would be able to go back if something unfortunate happened or you didn't have the outcome that you wanted. These groups are really being subsidized by their countries. And to make more money, they're upping the volume of having people come over. So the country itself is also paying for the basic infrastructure of care. And then these people are adding on because they're paying for, through their insurance, to receive these services. Now, let me go back to your original question: is why is hip surgery $100,000 in the U.S. and only $13,000 in 660? 13,660 in Belgium, because I read that article too. It was a great eye-opener for everyone. Well, first of all, these countries are generally very inexpensive to live on. They pay their healthcare personnel a much lower salary. They may not have the latest technologies, and that is significant when you think about the U.S. as a leader in that. And then finally, these particular places are only taking those folks that can pay. So there's no markup on the amount that you're paying for a service to cover what we call in the U.S. charity care. And I think that's a significant difference about why our costs are so high. Every U.S. hospital must take whoever walks in to their emergency room. They cannot turn them away. And who's going to pay for that? The cost shifting has to come from somewhere. So those are a couple reasons why our healthcare costs are so high.
Yeah, so then why is it that it's cheaper in Western countries than it is in the U.S.? Because I imagine that, if someone who's British wants to go and get a hip replacement in Britain, it'll cost significantly cheaper than if they were to go anywhere else. But in the U.S., if we want to get a hip replacement, so to speak.
You're right. It may the idea of the customer demand and the ability to pick and choose in the market is out there, but it's not what it would be in another country. In another country, such as Britain, let's give that example. You have the public health care system subsidized by the government. You would go into a line. In other words, you would be put in a queue. And when there was an opportunity, when the supply was available, you would go for your hip surgery. You could walk into almost any major U.S. hospital today and schedule a hip surgery if you had your surgeon within 2 to 3 weeks. And that's the cost of having that professional expertise around is part of it.
Is that to suggest that that Britain doesn't have the expertise that the U.S. has?
Not to the extent that the U.S. has, and I don't want to downgrade any other kinds of healthcare systems because they certainly have. But the U.S. is usually on the cutting edge of many new technologies. That's only that may only be one component of it. But the other part that I want to talk about is the idea that they are practicing. The other countries are practicing a standardized system, where in the U.S. we still have a very fractured system. And I'll give you an example. Let's look at New Jersey. One of the things that I can tell you about New Jersey is that we have a lot of hospitals, and they compete against each other. And they do the latest and the best. And this all raises the cost of what you're looking for. But the piece that I want to put across is the idea of our culture. In the U.S., if you fall down, let's say you fall down, and you think you've broken something, and you go to the emergency room, and they say to you, we're going to do x-ray on it. And you go, wait a minute, this happened to my buddy 3 weeks ago, and he got an MRI. You're going to say, why don't I get an MRI? Well, an x-ray costs about $85. An MRI, we're talking about $800. So that's another reason why we are so expensive, because our culture demands this high-tech medical treatment.
Now, do you agree with this culture?
Well, I don't. There's pieces to it that we all have to consider. If you and I are sick, we both want to have the best care, don't we?
Yeah.
Okay. So, we're dealing with that, and rightfully so. But I think what we also have to acknowledge is that we are very much a medical model in this country. It's fractured. It's different hospitals, different physician groups. The medical model says, let's treat the disease. We've got the best, the latest. What other countries have done is focused on the preventive model, which is really relying on the primary care physician and using that primary care physician to take care of the person from the very beginning and to help them prevent disease and wellness.
Thank you, Professor. Now, I would like to move on and talk about the Obamacare, or precisely the Affordable Care Act, as some people do not believe. So can you give us a Cliff Notes version of the bill?
Well, I really like the idea that you corrected yourself because it is the Patient Protection and Affordable Care Act. And people, there's different names for it, but the Affordable Care Act will do. To give you a short summary is next to impossible. As the the navigators that have been hired to get people to sign up for it have learned it's very, very complicated. However, let me just try and summarize for you the most important part of it. And that is the idea that we are focused on providing affordable health care, but one of the main pieces that we are looking at is thinking about access. In other words, we're providing an insurance option to 48 million people who didn't have the opportunity to get health care. Now, the key piece of this whole legislation is the idea of what we call a health care exchange. And a health care exchange is nothing but an insurance pool. Now, what has happened is some states have opted to create their own insurance pool. Other states have opted to use the federal version and expand their Medicaid pool of people. But what the Affordable Care Act does for someone who is uninsured is it allows them for a reasonable payment to receive health care. And the health care that is provided is mandated. It's an essential benefit. In other words, you're not going to get a luxury, what they call a luxury package. You are going to get the basic benefits that you would need as an individual in terms of just basic health care.
So, in essence, making health care affordable.
It does make it affordable, and the reason that it does this is because it's mandating that everybody has to have insurance. So that risk is spread across all a large population. And we know that the more younger people that are in these pools, the more successful they're going to be because it's spreading risk across everyone.
Now, on your opinions about the Affordable Health Care Act, do you think that it's a milestone in U.S. healthcare?
Oh, absolutely. I will share with you that in the 1990s, I taught for one semester the Health Care Act that was the proposal that was developed by Hillary Clinton when Bill Clinton was president. And her group was the originator of that common health care exchange. So folks like me have been watching this for the last 25 years. It is absolutely a watershed in healthcare, whether you agree with it or not.
No, of course I do.
The system was broken. It's too fragmented. It's going to put us into debt unless it was changed. This was an alternative. It got passed. It got challenged by the Supreme Court. It got upheld, and we're going to take it from where it is and go forth. I'm sure there's going to be many changes to it as it evolves, but it's a step in trying to rectify what has not been working for those 48 million uninsured.
And I know there are there are several opponents to the the Affordable Care Act proposed by President Obama and, its recent passing. And could you give us, I guess, a reason or your thoughts as to why people oppose it so heavily?
Well, I think there's a fear. There's a fear that it's going to be universal health care and that health care is going to be rationed. And by rationing, I mean that we will have lines in the U.S. If you add 48 million people to a system, are we going to be able to take care of all of them? Do we have enough primary care physicians? And I think there's this fear that the American citizen is going to lose their choice. I think on the other side, what we will see through different kinds of vehicles, such as the accountable care organizations, where now we're making the physicians in the hospitals responsible for the outcome of the patients. So they're monitoring them much more. I think we're going to see efficiencies in that, and that's going to free up our system. The second piece that I do like about it is this whole focus on prevention and wellness and looking at getting people screened and making sure that our seniors get their flu shots and making sure that children receive all of their vaccinations. Even to what I see when I'm teaching my college students, and that is those under 26 sometimes don't have health care insurance. Now they're going to be covered. So those are some of the successes that I've seen in the Act so far.
And if you could make anything better, if you could improve on the Affordable Care Act, what would you do?
I think I would add some additional incentives for providing quality care. I think that what we have right now is wonderful, but there's huge variations in our system in how we follow up people, how we prepare them to how they use the healthcare systems, and I think that we need to do a little more focus on finding out what works and how can we improve the quality of our care. And I think the first step for that is going back and looking at how people take care of themselves. The best example I can give you of that is our emphasis that we have the last few years on childhood obesity. The benefits from that emphasis and having people focus on exercise, especially children, we're going to reap benefits from that years from now, because that's going to help us prevent the diabetes, the chronic heart disease, and some of those other issues.
Right. Well, thank you, Professor Hewitt. Really appreciate it.
Okay. It was nice to talk to you.
It's nice to talk to you, too. Take care.
Bye-bye.
And this is Fadesola Ojeikere from the Global Current.
The man who has been called Ireland's most dangerous criminal was released from prison this Tuesday after serving 17 years of a 20-year sentence. Crime lord and drug baron John Gilligan, 61, served 17 years in prison after being convicted of possession with the intent to distribute almost 45,000 pounds of cannabis. Although originally eligible for release in 2011, Gilligan was handed an additional 2-year sentence after he was found guilty of assaulting a prison officer. Gilligan was also caught twice illegally using a mobile phone in prison, further adding to his sentence. John Gilligan was originally detained on the suspicion of his involvement in the murder of Veronica Guerin, one of Ireland's most well-known crime reporters. At the time of her death, Guerin had been investigating Gilligan's various criminal enterprises, particularly the influx of heroin into the country in the 1990s. Upon his release, Gilligan's family welcomed him at their home in Clondalkin, County Dublin, with a festive celebration. While the Gilligan clan celebrated, Veronica Guerin's brother Jimmy told Britain's The Guardian that he would not be surprised if Gilligan returned to his life of crime. He said, quote, "He was always a criminal and thug and will go to his grave as a criminal and thug." Veronica Guerin began investigating Gilligan's ties to Ireland's drug trade for the Sunday Independent in 1995. Guerin was able to tap into a broad network of underworld sources by accurately reporting information without breaking Ireland's libel laws, which make it illegal to name suspected criminals. She spoke of her unique methods and these laws in the years before her death. On one occasion, after questioning Gilligan about the source of income that supported his lavish lifestyle, she was violently assaulted by him. Before Gilligan could be brought to trial for this beating, Guerin was murdered on June 26, 1996. 2 men on a motorcycle shot Guerin 6 times while she was stopped at a red light on a road near the town of Clondalkin, County Dublin. Though Gilligan was at the top of a list of suspects wanted in connection with her murder and charges were brought against him, he was ultimately acquitted. However, 2 of Gilligan's top lieutenants, Brian Meehan and Patrick Holland, were tried for the slaying. Meehan was alleged to have driven the motorcycle while Holland is widely thought to have fired the fatal shots. Meehan was found guilty of attempted murder, but prosecutors could not secure the evidence needed to convict Holland of murder, and he was acquitted. He was later found guilty of possession of cannabis for sale or supply and died of natural causes while serving his sentence in 2009. The criminal underworld's involvement in Guerin's high-profile killing spurred Ireland to create the Criminal Assets Bureau, or CAB. Formed just months after Guerin's murder, the CAB was given the power to seize the assets of suspected criminals. The CAB was founded on the multi-agency concept, bringing together specialists from various fields to work together in the pursuit of serious criminals and their assets. Rob Wainwright, the current director of Europol, singled out the CAB as a role model for the rest of Europe, and has since introduced a similar model for criminal asset recovery within Europol, the European Union's chief law enforcement agency. Back in Ireland, John Gilligan has been pushing back against the CAB. He lodged a new complaint in Ireland's High Court over the legality of the sale of his estate called Jessbrook in Leinster. Jessbrook was seized by the CAB shortly after Gilligan was sent to prison in 2001. Current CAB chief Eugene Corcoran told the Irish Times that Gilligan's latest challenge has no legal basis and his attempts to frustrate the sale will have no effect. Aside from proceeding with the sale of Gilligan's seized assets, the CAB does not currently have plans to continue to monitor John Gilligan, leaving Ireland's most dangerous criminal free to go about his business. This is Laura Toledo for The Global Current.